Dr. Deepinder, our chief instructor, will take the next talk.
Yeah, I think in interest of time, it was very interesting discussion. We could have extended it. Temponad is always a so I think I'll start from where Dr. Reddy has left. A lot of points he has very well covered also. Uh, but why we need bimanual dissections in PDR surgery? Because there are two things we are worried when we are addressing these cases. One is a retinal tear, and second is bleeding. If you see, these are two core issues, and I think tear normally happens whenever, whether it is spontaneous or iatrogenic, it will almost always happen at the base of neovascular complex or around that neovascularization, because retina around it is ischemic and more fragile, and traction is strongest at that point. The adhesion between vitreous and retina is strongest at the neovascular complex. And if you see, this is just a spontaneous break. It is at the base of neovascular complex. And when you are operating these cases, I think Dr. Reddy has already laid out that your strategy is to address it from outside and leave the thickest membranes at the end. So I'll just taking it forward from there. So this was again a very aggressive PDR TRD in a young patient. Now, if you see, this is actually an unedited video. I'll just try to show that when we are discussing that you are going bimanual and you are trying to go around the neovascularizations, not disturbing them, what do we mean? So when we are starting, you just transect the weakest connection, the thinnest connection between neovascular complexes, and spend some time when you before you start, and you realize that thickest and the widest portions are the areas where you have strongest and biggest neovascularizations. So try to dissect in between these islands. I usually call them islands or pegs, and separate them from each other. And bimanual actually makes your job easier, faster and safer. So I would rather recommend going bimanual for all these TRDs. I think it's worth it. And you can combine multiple forceps. You can combine forceps with cutter. You can combine diathermy with laser. You can combine aspiration with cutter, depending on the situation. So it actually adds lot of hands to your armamentarium when you are bimanual. And again, just like what Dr. Reddy was showing, that first you separate the bigger islands from each other, and then you start addressing each bigger island and try to make smaller islands out of that. Anyway, we are in the city of islands right now, so we have to create these islands when you are doing these PDR surgeries with TRDs. And this video I have chosen just to show you that a thick fibrovascular membrane is actually composed of so many neovascular complexes. You see all these white lesions in retina, they were all neovascular complexes which have joined to form a thick fibrovascular membrane. So idea of operating them is to, I think, bring it back to where it started. It started with these neovascularizations. So separate them from each other and create these islands. You will see in the end, and in post-operative picture also. You see all these residual stumps of neovascular complexes, they are harmless. And if they are encroaching posterior pole, Dr. Ajay would be speaking about it. An additional maneuver you can do is peel the ILM so that when they regress further, they will not exert traction on macula. Now, these things are little different from our conventional PDR surgeries when we were operating them at the later stages, when we were doing heavy PRP, neovascularization used to regress. Here we are operating on neovascularizations which are still regressing and they are still active. So even when you have done your surgeries, they will keep on regressing in the post-operative period. They will increase the traction. So that's why probably ILM peeling and creating the smaller islands is good enough. And my colleague, I'll show you a few pictures at the end of presentation. This is another case similar. You see the thick fibrovascular sheet, and I just wanted to, this is for the interest of fellows, that how do you decide where to put chandelier? This is again a important part. Now you put your 3 ports, put your endolight and examine the retina and see where is your core pathology, where will be your main dissection. And just opposite, like in this case, it was in this temporal area. This is the right eye. So this is the temporal area. So I am putting the chandelier diagonally opposite to that. But sometimes if you have a nasal membrane, then don't do that. Then do just opposite. Put chandelier temporal. And sometimes you have pathologies in multiple quadrants. You can always rotate the chandelier also. Don't hesitate. These are all 25 gauge ports. You can create as many and they close spontaneously. So if you have more than one pathology, you need not have 2, 3. Somebody suggested have 2 chandeliers, 3 chandeliers. You don't need. I think you will be addressing each pathology one at a time. So you can shift them. So rest is same. I think all our VR colleagues are now addressing these similarly. We don't try to peel these neovascular complexes. We just segment and break them into multiple small islands. And disc is often a good point where you will always find a plane. So that's the only area where we can peel off and create a plane and then start segmenting again. Yeah, I think there is a video missing here, but again, I wanted to show here in this video was that sometimes a very clean looking case, vitreous hemorrhage, you start operating it, remove dense vitreous hemorrhage, and in the end you realize there is a foveal neovascularization which is tightly adherent. Then also you don't hesitate to shift to a bimanual mode. You insert a chandelier and then because it is much safer to handle a foveal neovascularization bimanually rather than doing it unimanually. You can actually segment around it. Now, this was again a case where I just wanted to show that TRD progressing and we operated and these are all residual neovascular complexes. Now, a colleague asked me this question, you are leaving these neovascular complexes, stumps, what happens to them in long run? So I tried to take out all these cases and just to show you that they regress and if you have peel ILM, they maintain good vision, macula stays healthy. So I think you don't need to disturb them a lot, just segment them from each other. Another case, you see segmentation and long-term follow-up. Even with this kind of large areas which have been dissected from posterior pole, they are very well tolerated. So to conclude, I think we should try to plan most of our PDR TRDs as a bimanual surgeries, as I already highlighted. Use forceps with cutters, spatulas, long 26 gauge needles. You can combine them. Identify the thickest neovascular complex, separate it from all those other smaller epicenters and leave the thickest part at for the end. First you approach the larger islands and then separate them from each other and then you can come back to each island and make small islands out of that. So with this I think I'll conclude and I can take questions if there are any. Thank you.
Dr. Deependra, I mean, regarding the islands, I mean, the first video that showed that quite, I mean, with the 25 gauge, you can reduce the size further also and that.
Absolutely. I think it's more, it's all about patience. Smaller islands you create, better would be the results. And closer the islands are to posterior pole, try to make them smaller. And the nasal ones, you can still leave them as bigger islands. But if they are in the posterior pole and macular area, try to almost separate all smallest new vessels from each other. And there is always a plane in between two new vascular complexes. All we need is more patience and we have to spend some more time and you will find a plane. And if you are not getting plane from one particular clock arc, approach it from the other side. You will find a plane diagonally opposite.
I think one thing I would want to re-emphasize again is once the instrument is being you are trying to insinuate the instrument behind that fibrovascular stalk, and don't try to lift it directly vertically up. You should try go around, because many a times there is a fine flimsy membrane which will continue extended towards the periphery. So you make a curvilinear motion rather than a direct motion towards the stalk. So make sure that the stumps are all isolated and there is no second membrane between them. So second membranes, if they are there, these stumps will cause problem.
Right. Agree. Yes. I think Dr. Ajay, you can take that mic. If you can come.
You can use a mic, sir.
Dr. Ajay.
Hello. Just that if you are not finding the plane, it's too difficult. And then we can try ileum peeling surrounding that. Wherever ileum is gets stained, we can peel, and with that we will get that plane definitely. Almost always we will get a plane to lift up that. So
excellent point. I agree. Fully agree with this. Yes, sir. You had a question.
So if you're a right-handed surgeon, how do you dissect your left eye nasal TRDs and membranes?
I think most of us are now ambidextrous, and I encourage fellows, especially in VR surgery. I think we do ILM peelings also with left hand and all the dissections. You can be slower than when you are doing it with your dominant hand, but I think this is something one has to practice. Otherwise, I think you can still do it, but I think the safety gets better if you are able to shift hands. In interest of time, I have not shown this, that how shifting. Maybe I think in the next video I'll show my next presentation that you have to shift your hands. Sometimes you have to shift from right to left and left to right. You can shift your ports also. I think surgeons have to improvise when we are doing PDR surgeries. Maybe Dr. Reddy can.
Yeah. I mean, I think it's you asked regarding the question, how do you handle the nasal membranes?
Yeah, in a left eye for a right-hand surgeon. So.
You have to use bimanual surgery. I mean, you have to be ambidextrous in some way or the other to.
You can shift the microscope temporarily, like the cataract surgeons do. You can sit temporarily and approach it this way.
You talked about making eyelids.
Yeah.
Do you make eyelids over the disc or you feel transpiration from the disc?
I think most of the times we'll peel off from the disc unless it is a isolated NVD and there is no traction in surrounding area. Peeling at disc, normally we exploit this only when there is a traction in the adjacent area, especially the macular area, and you are not able to find the plane like Dr. Reddy has shown beautifully in his video. Then disc is probably, I think, area where you can just peel the NVD and then just extend it little bit before it reaches the closest neovascular complex. Don't try to peel it from there. You will have a posterior pole break. So the whole idea is around half disc diameter area around disc is quite safe. It's very rare to have a neovascular complex in that close vicinity of disc, especially on the temporal sides and superior and inferior. So that is what we exploit sometimes.
One important point, I think, about shifting the chandeliers is in MIBS we have a great advantage. We can put chandelier in any of the ports. Even 23G ports, we can put a 25G chandelier. I've done it many times and it's very easy. I even change infusion many times.